So good afternoon, everyone, and welcome to the panel discussion. So to start things off, would you mind introducing yourselves, please?
Certainly. Hello, my name is David Berridge. I'm the Deputy CMO in Leeds, and I was the Executive Lead for the Scan for Safety Programme in Leeds, and going forward, the Executive Clinical Lead for the WYAT, which is the West Yorkshire Association Acute Trust Scan for Safety Lead.
Thank you.
Good afternoon, everyone. I'm Richard Corbridge. I'm the Chief Digital and Information Officer at Leeds Teaching Hospital and the SRO for the Yorkshire Number Local Health and Care Record Exemplar.
Hello, good afternoon. I'm Chris Slater. I'm the Associate Director for Commercial and Procurement for Leeds Teaching Hospitals. I guess I was the initial commercial lead for the GS1 Scan for Safety programme for Leeds, and sort of commenced with the journey to where we find ourselves today.
Nice to meet you all. So today's session is all about the GS1 standards supporting improved quality of care at Leeds Teaching Hospitals. So the first question I've got is for you, Chris. And the question is, you've been on this journey since the start. Why this project? Why and how did you engage senior clinicians and management? After all, this is about procurement and supply chain, surely.
Yeah, sure. As you say, it's been an absolute journey, and what I'm really pleased to see, today, 4 years on, with 200 to 300 people still in the room talking about Scan for Safety and GS1. So it's been a fascinating project to be involved in. I guess it started with, Monday morning, 2016, euphoria. You've got the project, you're a demonstrator site, fantastic. Tuesday morning, I think it turned into blind panic for me. The clock is ticking. And what does this mean, and how are you going to deliver it? Because at that point in time, we clearly didn't have a project team on board. I think, from my point of view, there was two objectives that we needed to deliver. And whilst we understood the core enablers, the product, the place, and the patient, this to me was very much about A, waste reduction, and B, patient safety. We understood quite a bit about waste reduction, particularly in supply chain, and we've known for some time there's good evidence from industry that we have lack of data standards within the NHS, procurement and the P2P processes, etc., but not particularly good data from the clinical point of view. I think the upside, the downside from the project was it had to come through finance because it sat within the enablement strategy. GS1 standards sat in the enablement strategy to start with. I think what we had to do initially was make sure that our clinicians understood that this was not a cost-cutting exercise. All too many times finance is seen as a cost-cutting department, and we're here to take away. Really, this was about understanding our commercial drivers, what we wanted out of this: visibility, reduction of waste, inventory, management, and so forth. But actually then turning to our clinicians and understanding what frustrates them, what takes them time to complete. So, I'd never really understood that finding your patient was a difficulty within the hospital. I'd assumed that the patients are on the PAS system and everybody knew where they were, but actually that wasn't the case. So listening to clinicians was the first sort of start of the process. And I guess to that extent, what was quite helpful from my point of view, and I don't know if people in the room remember, going back to 2015, 2016, we kicked off with the GS1 LoRa video. And that was quite useful just to sort of set the scene of what GS1 was. So I suppose I hawked that around, got the board sighted on waste management and the patient safety, but then listening to clinicians, listening to colleagues like David. What does it mean to you? What do you spend your time? So, product recall. And when clinicians produced the books with little stickers on, piles and piles and reams of books, trying to understand where products have gone and so forth, you realise how much time is being wasted in the business. So sponsorship from the top, clearly from the board, and then listening to the clinicians with the view not to burden them. This isn't about giving them, I think there was an initial nervousness, if you like, about, well, I'm going to have all these scanners, and we're going to have a belt full of scanners, and we're going to be scanning that, scanning that, scanning that. No, it has to be appropriate, and it is about taking time and out of the system, not adding the burden.
Right, thank you. And David, in what ways are patients safer in Leeds thanks to GS1 standards compared to, say, 2 years ago?
So, following on from what Chris has said, a few years ago, if any of our clinicians, whether they be medics or nurses, would come in the morning looking for their patients after the acute take, they have 114 wards to choose from. And particularly with winter pressures, there would be some patient movements clinically necessary. There'd be some patient movements that we would have to do for logistic reasons to free up more of an acute bed for the sicker patient. So when that physician is trying to track all their acute patients, 2 years ago, that would be a really hard task. You'd have safari ward rounds. What we're progressing to now, we're not there yet because we have so many wards, but by December this year, we will have full 24/7, 365 patient traceability. And that's important for every member of staff in our trust. Whether you are a porter, whether you are a ward receptionist, whether you're a receptionist in MR or CT or theatres, you will be able to know precisely where your patient is, to the bed level. So we have this in our digital wards, and with people like Jackie's help, we're making sure our staff are fully digitally trained, so that we're encompassing this with full digital ward. So you have full electronic patient record, full EOBs, full eMeds, and so that ward goes entirely digital as per the rollout. We already have EOBs throughout all of our adult wards, so that you don't have the risk now of having inadvertent errors placed in patients' notes. I could give you examples, for example, for a patient going for a liver transplant who missed their liver transplant because of a single reading of a temperature of 38 in their record, which meant that they were not eligible for that transplant that night. Why? Because potentially they could go into acute bacterial peritonitis, and that would be a life-threatening event. The trouble was that recording was for another patient. Now, with the EOB system linked with barcoding that we now have throughout all of our wards, that is an impossible thing. You have to scan the patient before it lets you put the EOB system results in. And once you move away, you have to re-enter again where you are and where you are with that patient before you put any more entries in. And I could go on and on with different examples like that. But it means so much more in patient safety from other routes as well, because by doing this, we can make sure we don't have out-of-date stock. We're not wasting our resources on that. We can use those resources to buy the latest scanner, the latest microscope, so that our clinicians do have the ultimate equipment to allow them to do their job as carefully and as accurately as possible. And we all live in a financially constrained envelope these days. So the moment you have opportunities to remove waste from the system at any level, and this is one of those systems, that's why the clinicians embrace this. And we don't have any problem at all in Leeds and going forward in West Yorkshire with clinical engagement. The frustration is we want it yesterday. Yeah. But we need to do that coaching and learning as we go along to make sure it's embedded appropriately.
Thank you. And a question for you, Richard. So we know business systems, there's many, they're varied, they're complex. How did you go about joining all the dots together?
Yeah, so Jackie referred to earlier, 15, 16 years ago, Leeds took the decision to start to build its own electronic health record. And one of the principles of that is integration and interoperability against open standards. So creating an open platform that allows all the systems across Leeds to become known as the electronic health record. So whether it's medicines, whether it's imaging, whether it's order comms, no matter what's connected, it becomes the EHR for Leeds. And that's been done by creating a specific team in Leeds that does nothing else other than connecting systems. There are now 350 systems across Leeds that are connected. When David and his colleagues log in using single sign-on, they're presented once with the patient context across all the different systems. So one of the most wicked problems that clinicians face in an acute hospital today is multiple logins. We're moving quite quickly towards single sign-on, access to all the information about a patient in patient context. The difference in Leeds and a small number of other places is that that isn't limited just to the acute hospital. The Leeds Care Record has existed for 6 years, and that now encompasses 123 GP practices, social care, community care, healthcare, the prisons, and homes. And that now means that that information is viewable across the whole healthcare journey across the City of Leeds. And we think is probably one of the reasons why we were successful in becoming the local health and care record exemplar, because as we've done and delivered that in Leeds, we're now moving towards delivering that across Humber Coast and Vale and in Mid-Yorks. So that not invented here element that was mentioned in the previous panel, I think in the last couple of years has started to break down in the NHS, in digital in the NHS, as we start to share how to do stuff and sometimes even share the actual product of doing stuff.
And I want to ask, what's the feedback been like? And the reason I asked this, I met with Glenn, I think just under 2 years ago, and when Glenn took me through the GS1 standards, what came to mind was peace of mind, and that was on a patient side of things, but also for the healthcare workers too. So have you got any feedback from patients? Is this something we talk to them openly about? And to your teams, what's their feedback?
Very much so. On our breast ward, which is one of our fully digital wards, if you talk to nursing staff there or the patients there, they will tell you as soon as they arrive into that ward, they are aware that they are being tracked. Their relatives know they're being tracked, so that anyone in that entire system, whether they're on the ward or whether in the adjacent breast theatres, know precisely where that lady is in her journey, whether it's to ultrasound, whether it's down to have the imaging pins put in, whether it's still in theatre. So when the husband or the mother or whoever rings up to know where their loved one is, the nurse on their live record on the whiteboard can see precisely where they are in that patient's journey. It saves nursing time. Again, we've heard this referred to many times. Saves a lot of nursing time answering the phone, because you can give a much more quicker, accurate response, and it saves a lot of time for the nurses going to theatre and the patient's not quite ready, or waiting to try and find where the patient is in imaging. So it speeds up the process. It's a much more reliable process. And once they've got used to the technology, they actually like it. And whenever we've rolled out, and we're going to roll out to the 5 other acute trusts in West Yorkshire shortly, it's really important that you put on, live demonstrations, and we've done that, and we've invited a number of people in the audience to see those. And without exception, whatever healthcare professional comes to see those wants that facility, wants that technology, and it's just frustrating that we can't do it even quicker.
Right.
We had a patient that took to social media a few weeks back. As it turns out, a patient who's a regular attendee at LTHT with diabetes, she took to social media to point out that other places that she goes to, that doesn't happen. That track and trace, being able to find out where she is across the system, isn't there. And she's seen that with the nurse with an iPad in front of her on the whiteboard in the ward. I mean, it turns out the person is also a IT journalist, so she sort of appreciates it slightly more. But it was a really amazing moment to actually be contacted by a patient on social media saying, what you guys do, what this team does is making a difference to my weekly life and my condition.
Right.
And certainly from our point of view, and talking to staff now who are involved in products, getting products to theatres and so forth, the confidence there that the product will be in the right place at the right time is absolute. We've got away from the situation where staff are having to effectively hope that things arrive in time. That's driven out behaviours of, instead of ordering 1, ordering 2 just in case. And we've taken that responsibility, given them more time back to the front line to deal with patients and spend time with patients, but given them the confidence that when they want it, it's there, it's the right item, we've got the right product for them, and it's fit for purpose. And by that I mean that it's in date, it's suitable for use, etc. So it's about confidence.
If I just mention, one of the speakers this morning mentioned about product recall. And one of the real pleasures now that we've got the system in, and I think it was Salisbury that mentioned it, is that when we get a product recall now, within a matter of minutes, we can actually inform our patients who may have had that product implanted, or reassure them they haven't got that relative device or that particular batch number within minutes, whereas in previous times it would have taken days, if not weeks, for very large numbers. So there's lots and lots of layers where we're adding to the quality of that patient's journey.
And Chris, you mentioned confidence. With the nurses or the force on the wards, knowing now that risks are at a bare minimum, have you seen this the way it's affected the teams in the hospitals?
Well, certainly, as I say, it's driven down the amount of time they're having to involve in supply chain activity. It's made sure that, or it ensures that we've got minimum values of stock and cash tied up to spend on other things because the right items are there. I guess, and feedback from only last week, be it the year end, we've had staff in the past coming in, over the weekend at the year end to do massive amounts of stock taking, taking them away from their day job, etc. That's all been done for them. The system does it for them now. We maintain that over the year. So again, that is taking that waste out of that supply chain system.
Right. And I'd like to open to the floor. Does anyone have any questions? I've got a question just at the front here.
Stephen Gowrie-Smith. I'm a pharmacist and health informatics advisor to the Royal Pharmaceutical Society, the professional body for pharmacists. I'd like to know what difference GS1 has made for pharmacists in your hospital and in your healthcare area.
So initially, as you know, there was quite a delay to get the national software system to allow some of that tracking to go forward. And I think Plymouth has taken a bit of a march on this with Ian Davidson is going to be giving a talk, I think it's later today, maybe tomorrow. In our own institution, we're still at the point of scanning within the pharmacy itself. In terms of going out to the patient, yes, we've rolled out e-meds throughout the organisation, but this is one of the developments that we need that embedded into the EHR as well, along with the EOBS. And we've got that in our digital wards, but we haven't got that yet through the organisation. But you're right, we do need that GS1 technology rolling out to the patient's bedside to avoid some of these transcription errors that we're getting. eMeds has largely done that across our wards, but we want that full integration piece to happen, and we're not quite there yet. I don't know, Richard, whether you want to...
Yeah, so we're doing 20,000 doses a day. The volume eMeds deployed across LTHT is the biggest DXC implementation in Europe, but we haven't got that integration to the GS1 standard yet. We know what the roadmap is, we know how to get there, but it's taking longer than it should, and I think that's symptomatic of some of the conversations this morning, and particularly on the last panel, around the speed that we want to move forward with technology and the speed we can actually move forward with the journey being transformation and not about the IT part.
Is there anything you wanted to add, Chris? No. Thank you for your question. Is there any more questions from the floor? Okay. I'd like to ask, if you were to reflect on a journey, what would you do different?
Chris?
I think it's difficult to say. There was no blueprint here to follow. We were making it up as we went along to a certain extent. So difficult to say, what went wrong at the time. We were learning as we went along. I think we're in a different place now. I think what we need to do is absolutely take the learning from the demonstrator sites. We've been very keen to document the journey to ensure that if we have made any errors along the way, that we've recorded those and that we help colleagues around the NHS not to follow in our footsteps. So I think it was definitely and was a voyage of discovery, I guess. But taking that, we started off this morning talking about the evidence. I think we've now got a good base of evidence around Scan for Safety GS1 that we can impart on the wider NHS now.
I think one of the things that we have learned and we've fixed is where to place the governance and ownership of the project. That it was very much a procurement project when it started that had some fantastic unintended patient and clinical consequences that when the project was started, we were not clear were going to be so easily implementable into our EHR. And that's meant that we've played catch up a little bit with our governance. It's been great that David has always been the lead clinician for this all the way through, whether it was a procurement project or indeed now a clinical project, it hasn't mattered. But the way that the digital team has worked with procurement and then with clinicians has needed to change because it's a very different job to implement GS1 into a procurement system and stock and control system than it is into an EHR and a patient monitoring. But it's a lesson well learned.
Yeah, and I think the opportunity is there for the transformation piece. So, time and time people have said it, and I fully agree with them, that it's not sufficient just to go straight analog digital. You're not going to cure anything that. You're not going to undergo any transformation. You've got to co-produce that transformation as you're going, or in that journey from analog to digital, to really get the full benefits from that. Because they are many and varied. And I think the advantage of the Scan for Safety pilot sites, all 6, I think we all learnt off each other. There was very good cooperation at all different levels within that grouping, and we all learned from each other over that 2-year cycle. And each of those demonstrator sites has come out with a slightly different nuance, but the basic thesis is the same throughout all 6 sites. And somebody was saying before about, why hasn't it rolled out beyond the 6? Well, I do believe it has. Each of those sites has got allied hospitals that are working with it to implement those changes. I think Lorna referred to other hospitals such as Salford, who were on the podium earlier on, who are obviously one of the exemplar digital sites. So there are a lot of hospitals doing it, and hopefully we can do a little bit more in West Yorkshire shortly with bringing on another 5 acute trusts.
Right. And with staff turnover, how easy is it to bring the new teams up to speed with GS1 standards?
I personally think it's relatively easy because you've got that embedded culture throughout your organisation. So yes, where you've got areas of turnover, the nurses in those areas, the porters in those areas, the ward reception staff, the doctors will all know those systems. And we regularly put on extra training sessions to account for those new staff. So I don't think that's a particular problem. I think our biggest problem that's going to be for all of our sites is once we have that full digital technology, it's trying to control the enthusiasm and the desire of our clinicians to do 101 things when we only have the resource to perhaps follow 20 of them at the first hurdle. So that's the ambition and that's the vision that we have. We mentioned before, I think Terence mentioned a bit, why should he, when he runs his clinic, have to open several different systems? Well, as we've heard from Richard, we don't have to do that now. It's one login. But we're still going towards, ultimately, that when we send our electronic discharge note to our general practitioner colleagues, it should have embedded in it the prosthesis that's gone into that patient with all the relevant details. So should that patient need to go to any other NHS hospital, they can access exactly what that prosthesis is, when it was made, what the batch number is, how they would need to modify it. All the electronic prescribing should be automatically uploaded into that same electronic discharge note. So it's a fully digital system. And we've mentioned the Leeds Care Record. I think it's the Northern Care Record that Alan referred to before. You've got to have that full accessibility from primary care through to tertiary care to make it easier, so you don't have to keep putting on patient demographics, their medications. You can just do the updates, so the GP and their nurse assistants in primary care can readily see what changes you've made rather than the great tomes of narrative.
Yep.
Yeah, I think the other thing, Anthony, is that we've definitely seen a shift from a project-based approach to Scan for Safety to a business as usual. And people now accept, we walk around, we talked about the GLNs around the rooms, everybody, they can see them, it's very visible. It's just the norm. So when people come on to be, if you like, trained on the job, it is just the norm. So it's now very much embedded into the organisation.
Right. And opening back out to the floor, is there any more questions? No. So from your own disciplines, what's next on your agenda and how will it impact even more patients?
Okay, so maybe I should start. There's lots of projects that we're looking at. We truly want to go patient back to patient for all blood products. So it's insufficient for us to scan the patient's blood product from the blood bank through to blood fridge and then revert to a manual system to go back to the patient. That's ridiculous in this day and age. We should scan the patient at the bedside. That GS1 code needs to be on the blood sample. It needs to be tracked all the way through the system back to the blood fridge and then scanned out of the fridge and scanned back to the patient at the far end. That's what we're working on, and that's what we want to implement across the trust. We're also looking at, again, the HUE checklist. Can we scan every single patient in our trust now? Yes, we can. Can we scan every single one of the 25,000 locations they can go to into any of our 7 hospitals? Yes, we can. Can we scan to the theatre room in front of every intervention room? Yes, we can. Can we scan to the theatre list? Not yet, but we want to. And when we scan to that list, that then brings in the OPCS code and the side. So in other words, 1/3 of the 450 never events that happen in this country every year, 1/3 should have a potentially scannable solution to avoid.
Perfect. Yep, sure.
I think David's mentioned a couple of times the WIAT, West Yorkshire Association of Acute Trusts. We've been very fortunate to apply and been given some funding to roll out Scan for Safety across the other 5 trusts in West Yorkshire. I think from my point of view, and the procurement is now a work stream, as I say, it's not leading the project, it is a work stream within the project. What we're aiming to do is, and we've talked, one of the issues within a trust is the catalogue management, the number of products that we're managing. What we're looking to create across WIAT is a single catalogue for 6 trusts. We're looking to create a single inventory solution for 6 trusts. So we've got a view not only now of our hospital, but we'll have a view across the wider trusts, the 6 trusts that we're talking about. So why shouldn't we then start looking at economies of scale around what products are held within the region? Why do we all hold 4 of each when effectively a few miles down the road there are other products? So we need to think about the waste we can take out of the supply chain across a wider number of hospitals.
Thank you.
And then I guess there's the last one's looking at connecting to monitoring machines, dialysis machines, etc., identifying them through a GS1. So a nurse is going specifically renal at the moment up to a renal machine, tapping it with her pass, scanning the machine, taking the feed directly from the machine into the EHR, not having to write down, transcribe, move information around. And once we get there and identifying to that level, we start to truly have almost a human intervention to check rather than human intervention to record.
Thank you. One last push for questions from the audience. Okay, well, I'd like to thank you for your time joining us on the stage and wish you all the best going forward. Thank you very much.
Thanks.
Thanks.